Question number 53. A 21-year-old primigravida woman at 39 weeks of gestation by uncertain dates attends the antenatal clinic at the local hospital for her first antenatal visit. She has just arrived from overseas, having had no antenatal care in her country of origin. Her blood pressure is 120 by 80. The fundal height measures 30 centimeters above the pubic symphysis. Fetal heart tones are evident at 144 per minute. Pelvic examination revealed the cervix is long and closed, and the baby is presenting cephalically. Which one of the following is the most appropriate next step in management? Options are fetal kick chart, cardiotocograph, amniocentesis, ultrasound examination, umbilical RT waveform Doppler. The scenario presents as an example of fundus height probably smaller than suggested dates of gestation, except that the dates are uncertain. Head-sparing intrauterine growth restriction must be excluded, or if found, manage accordingly. So the most appropriate assessment would be an ultrasound examination, which would assess the various dimensions of the fetus, looking for evidence of discrepancy in size of the abdomen, limbs, and head, and would provide an assessment of the liquor volume amniotic fluid index. So option D is correct, which is ultrasound examination. First, we'll go with the ultrasound examination. If an ultrasound examination showed clear evidence of asymmetric growth restriction, further assessments such as a cardiotocography and umbilical waveform analysis would be required. Fetal movement counting would be applicable, and assessment of fetal lung maturity by amniocentesis could be proposed. If there was no evidence of asymmetrical growth restriction and the amniotic fluid index was normal, the ultrasound should be repeated 2 weeks later to assess fetal growth in the interim. If this growth was normal, this would allow calculation of the probable due date, assuring assuming the fetus is actually growing normally along the 15th 50th percentile of the population. So the first we'll go with the ultrasound examination, and then if any asymmetry of growth restriction is there, then we will go with the CTG umbilical waveform analysis, and fetal movement counting would be applicable, and then amniocentesis uh, could be proposed. So ultrasound examination is the first. Option D is correct. A 24-year-old woman present with bruising and excessive cyclical menstrual loss, which commenced 4 months ago. A blood count shows that she has a normal blood film apart from a platelet count, which is 20,000. Physical examination is unremarkable, apart from the enlarged spleen, which is palpable 3 centimeters below the left costal margin. Which one of the following the most likely diagnosis? So this 24-year young woman with bruising and excessive cyclical menstrual loss, low platelet counts. Options are iron deficiency, ITP, chronic lymphocytic leukemia, SLE, portal hypertension. So, and spleen is enlarged spleen, which is palpable 3 centimeters below the left costal margin. This clinical scenario involves a young woman with bruising and heavy menstrual bleeding over a 4 month period who is found to have a splenomegaly and significant thrombocytopenia. While excessive menstrual blood loss is most likely to cause a significant iron deficiency, the iron deficiency is a secondary problem and not the underlying diagnosis. ITB is an important differential diagnosis, but splenomegaly is not present in this condition. CLL is a disease of older adults where thrombocytopenia would be a late consequence of marrow infiltration. This condition is always associated with a significant lymphocytosis. The age, severity, thrombocytopenia, and the otherwise normal blood film makes the diagnosis extremely unlikely. SLE is the most likely diagnosis. SLE is an important cause of autoimmune thrombocytopenia and is commonly present in young adult women. The finding of splenomegaly is very suggestive. Other symptoms that were not present but which should be sought in such a patient include ST of Raynaud phenomena, polyarthritis, alopecia, or mouth ulceration. Portal hypertension may be associated with splenomegaly and thrombocytopenia. As a consequence of hypersplenism, it may be the first manifestation of chronic liver disease, as might occur with chronic hepatitis B or C infection. Bruising would also be consistent with this diagnosis, but physical examination would be expected to show signs of chronic liver disease. So the correct answer is SLE. So correct answer is SLE. It's a very extremely difficult question because how we can reach to the diagnosis of SLE from this low platelet counts and excessive cyclical menstrual loss, which is because of thrombocytopenia. But typical features of the SLE are not present. But again, we have to understand this scenario and we have to uh, correct give the correct answer. So answer is the SLE.